Good morning, ladies and gentlemen. The topic of today's lecture is the genetic disorders of collagen, elastin, and dermal matrix. Since this is a big chapter, I am going to split this chapter into two lectures. So today will be the first part of this lecture. So among the genetic disorders of collagen, elastin, and dermal matrix, I am first going to discuss the inherited disorders of collagen. The disease which is most important in this category is Ehlers Danlos syndrome. The Ehlers Danlos syndrome is a heterogeneous group of inherited disorders that is primarily affecting the collagen. Just remember that it is the disorder of collagen. And it is characterized by the joint hypermobility, the skin hyperextensibility, and tissue fragility. The original classification of Ehlers Danlos syndrome is into 11 subtypes. However, in 1986, International Nosology of Heritable Disorders of Connective Tissue redefined EDS into subtypes 1 to 8 and 10. All types of EDS have a frequency of 1 to 5,000 or 10,000. Whilst features may be present at birth, most patients present later in childhood as the diagnosis is difficult to make until the child starts to walk. There is no sex or racial predilections, and the disease is associated with osteogenesis imperfecta, pseudoxanthoma elasticum, Marfan syndrome, renal tubular acidosis, and medullary sponge kidney. So this picture shows the hyperextensible skin, and this is the original picture of my patient. Pathophysiology. The defect lies in the fibrillar collagen, an assembly of extracellular matrix molecules, including proteoglycans and transin X, which have been found to be the causal in different types of Ehlers Danlos syndrome. Pathology. Histopathologically, there is a loose, disorganized dermal collagen network. The elastic fibers are usually increased and oriented irregularly. The pseudotumors which are seen in classical Ehlers Danlos consist of fat and mucoid material in a fibrous capsule. Genetics. The spontaneous mutations occur in 30 to 50% of autosomal dominant subtypes, and less common type is autosomal recessive. So Ehlers Danlos is mainly an autosomal dominant type. Clinical features. The diagnosis of Ehlers Danlos syndrome should be considered in anyone with the cardinal manifestations of skin hyperextensibility, skin fragility, easy bruising, and joint laxity. So remember these four cardinal features. That's it: skin hyperextensibility, skin fragility, easy bruising, and joint laxity. Further features will depend upon subtypes of Ehlers Danlos syndrome. The classical Ehlers Danlos syndrome. So the classical Ehlers Danlos syndrome, or type 1, the skin is soft, velvety, hyperextensible, but retain the normal recoil. Skin of palm and soles may be hyperlinear and loose. The skin is not usually otherwise lax until later in life, when redundant folds occur on eye, which is called as the blepharochaliasis, and on face as well as limbs. The striae often do not develop during pregnancy, and trivial laceration form gaping wounds that heal very slowly and leave broad, atrophic, cigarette paper-like scars. Sutures may tear out repeatedly. So this is the problem in the skin because of the skin softness and the absence of collagen. The skin, the lacerated wounds are difficult to heal, leaving atrophic cigarette paper scars. Then the blue-gray spongy tumors, also called as the molluscoid pseudotumors, occur, which are due to accumulation of fat and mucoid material under a capsule. And they occur especially on the scars and over pressure points. So you can see these cigarette paper scars on the knee, and one of the molluscoid pseudotumor is seen on the elbow. These were all also the original pictures of my patient. Then in addition, you can find smaller firm subcutaneous nodules, which are called as the spheroids, which show calcification on X-ray, and they develop on shin forearms in up to a third of the patients. Easy bruising may be a presenting symptom, and pigmentation due to hemosiderin deposition is also found on the areas of repeated trauma. Facies may be distinctive, with widely spaced eye, wide nasal bridge, and epicanthic folds. The Gorlin sign is the ability to touch the nose with tip of the tongue. Is more common in those with Ehlers Danlos syndrome. So the sclera is sometimes blue, while it's not a normal feature of Ehlers Danlos syndrome. There is marked joint hypermobility, which can impair walking, especially during pregnancy. So most of the individuals who are working in circus and exhibiting their extreme joint hypermobility are actually the patient of Ehlers Danlos syndrome. Subluxation of large joint may also occur. Muscle tone is often poor and hernias develop. Pedal pisogenic papules are also frequent. Then systemically diaphragmatic eventuation and gastric torsion is reported. Symptomatic bladder diverticula may develop and varicose vein develop in early life. The physical and mental development is normal and life expectancy is not reduced. Then hypermobility type of Ehlers Danlos syndrome, this is actually type 3. The hypermobile Ehlers Danlos syndrome and joint HMS are both autosomal dominant and are considered to be the same disorder. The Bigton score is useful as adult score of 4 or more out of 9 is considered diagnostic of hypermobility type of Ehlers Danlos syndrome. And since joint is the main organ involved, skin is minimally affected, and there is a dislocation and joint pains are common. The extra-articular manifestations include syncope, palpitations, and fatigue, suggestive of dysautonomia, although the exact mechanism of these symptoms is not clear. Gastrointestinal symptoms are also common. So these images are those of hyperextensible skin, then hyperextensible joint in these patients of Ehlers Danlos syndrome. Vascular type of Ehlers Danlos syndrome, this is actually type 4. This is a severe form and inherited as autosomal dominant trait. The issue mainly is in type 3 collagen, and which is probably present around the arterial media, in the bowel, and in the uterus. So the patient exhibits clubfoot and congenital dislocation of hip. Other features include prematurity due to the rupture of friable placental membrane earlier, easy bruising, which can be mistaken from a child abuse, recurrent inguinal hernias, and pneumothorax. Many individuals have an acrogeric appearance consisting of prematurely aged, thin, translucent, fragile skin, a hollow-eyed appearance, thin peaked nose, and thin lips. The major complications include rupture of large arteries and colon and the gravid uterus. So these are the areas where type 3 collagen is in abundance. Most deaths are due to this arterial dissection or rupture, mainly of thoracic and abdominal vessels. And in the same series, the complication of pregnancies are seen, leading to death in 12 patients. 7 died of vessel rupture and 5 following the uterine rupture. Then X-linked type of Ehlers Danlos syndrome, which is also known as the type 5. 2 families are described. Clinically, it resembles the mild type of classical Ehlers Danlos syndrome, but bruising is more common. However, it is distinguished from the classical type by X-linked inheritance. Hence, it is seen in males and not in female. Until a precise genetic and biochemical abnormality is found, the status of this type remains questionable. Then is the Kyphos Scoliosis type of Ehlers Danlos syndrome, which is classified as 6A and 6B. Type A is autosomal recessive. This is different. Now, this is the first Ehlers Danlos syndrome, which is autosomal recessive. And biochemical deficiency is the deficiency of lysyl hydroxylase, leading to reduced hydroxylation of lysyl residues in type 1 and 3 collagen. The skin is soft, velvety, hyperextensible with increased joint mobility. The characteristic feature is the scoliosis, and many patients have Marfanoid habitus. The eye manifestations include microcornea, glaucoma, keratoconus, and ocular fragility. Bleeding may occur from major wounds, and there is delayed motor development. Type B or of Kyphos Scoliosis type has normal lysyl or pyridinoline and hydroxylase pyrrolidine ratios. Muscular contractural Ehlers Danlos syndrome was initially categorized as such. All are autosomal recessive, and in addition of typical Ehlers Danlos skin changes, share features of severe hypotonia at birth, delayed motor development, and scoliosis. So both type of Kyphos scoliotic type of Ehlers Danlos syndrome are autosomal recessive, and their main features is joint laxity and scoliosis, in addition to the soft and hyperextensible skin. Then there are rare types of Ehlers Danlos syndrome, like musculocontractural type of Ehlers Danlos syndrome. As the name signifies, it is characterized by multiple contractures, and there is distinctive craniofacial appearance. Then there is Ehlers Danlos syndrome with spondylochiric dysplastic form. This is important as it is characterized by hypermobility of joints and again progressive contractures. Then there is Ehlers Danlos type with progressive Kyphos scoliosis, myopathy, and hearing loss. So these are rare syndromes. As the name signifies, it is characterized by Kyphos scoliosis, then hypotonia, and sensorineural hearing loss. Then another common type or the main class of Ehlers Danlos syndrome is orthochalasia type. Ehlers Danlos syndrome, which is known as type 7A and 7B. This is autosomal dominant, and like osteogenesis imperfecta cause mutations, result from mutations causing defect in type 1 collagen. So type 1 collagen is present in the bones, and the most important feature are joint hypermobility, recurrent joint dislocations, and typically bilateral congenital hip dislocations. There is skin redundancy, resulting in one of the key features of orthochalasis type, namely criss-cross pattern on palm and soles. Then type 7, which is also called as dermatosperexis type. This is again autosomal recessive like Kyphos scoliosis type, and is characterized by premature rupture of membranes and extreme skin fragility, laxity, and bruising. So it results in serious complications like spontaneous rupture of bladder and diaphragm. The facial appearances is characteristic of blue sclera, puffy eyes, epic and thick fold, down slanting palpebral fissure, microgenthia with gingival hyperplasia and dental anomalies. Then periodontitis type of Ehlers Danlos syndrome. This is classified as type 8. So in addition to features of classical EDS, there is only moderate small joint hypermobility and milder skin manifestations. The distinguishing clinical features are premature periodontal recession resulting in loss of teeth by third decade and heavily pigmented pretibial plaques. So the main characteristic in addition to the features of classical type is the periodontal disease and loss of teeth. Then the 9, Ehlers Danlos type 9 is the occipital horn syndrome. It is an X-linked recessive disorder allelic to Menkes syndrome, but is no longer considered as EDS and is reclassified as disorder of collagen metabolism. So the fibronectin deficient type of Ehlers Danlos syndrome is type 10. One family is identified. Skin and joint changes are mild, but bruising occur readily due to defective platelet aggregation. So the cause is defective platelet aggregation in this case. So it is actually a clotting defect. Then progeroid type of Ehlers Danlos syndrome. Rare association is with progeroid features, the short stature, osteopenia, defective wound healing, and mental retardation. So if we revise these findings of Ehlers Danlos syndrome, the type 1 is the classical Ehlers Danlos syndrome, and type 2 is a milder form of classical Ehlers Danlos syndrome, characterized by the skin laxity and but retaining its normal it's characterized by skin hyperextensibility. Then the strias do not develop and scarring result, and the wounds result in cigarette paper kind of scars. Then blue spongy pseudotumors form. There is joint hyperlaxity and there is easy bruising, but both of these features are milder as compared to other subtypes of Ehlers Danlos syndrome. The Gorlin sign is demonstrated when you ask the patient to touch the tip of the nose with the tongue. Then the type 3 of Ehlers Danlos syndrome is hypermobility type. It is characterized by all the features of classical Ehlers Danlos syndrome with additional features of hypermobile joints and more chances of dislocation and joint pains. Then vascular type, which is actually type 4. This is characterized by defect in the large arteries because of the collagen 3 defect, resulting in vascular rupture and fatal deaths. In addition, bowel and uterine ruptures are also seen in this vascular type 4 of Ehlers Danlos syndrome. Then type 5 is the X-linked recessive, seen in male and has all the features of classical type, but bruising is more common. Then type 6 is the Kyphos Scoliosis type. Both type 6A and 6B are autosomal recessive. There are, in addition to the features of mild Ehlers Danlos syndrome, there is scoliosis and eye changes. Then these all are subtypes of Kyphos Scoliosis type. Then type 7 is the arthrochalasia type, where the joints show increase in mobility, dislocations, and bilateral hip dislocation. So the joint is more damaged here in this type. Then dermatospraxis, or type 7. This is related to 7A and 7B. So the type 7C is different from type 7A and B, that it is autosomal recessive. And again, there is skin fragility, laxity, and bruising, and with special facial features. Type 8 is periodontous type, in which, in addition to features of Ehlers Danlos, there is lots of teeth. Type 9 is occipital horn syndrome, which is due to copper metabolism defect in copper transport. Copper transport, also known as Menkes disease, but no longer is this is kept in the classification of Ehlers Danlos. Type 10 is the fibronectin type. Again, have an increased bleeding tendency, but because of the clotting defect, because of the fibronectin defect, there is a defect in platelet aggregation. There is a subtype of Ehlers Danlos in which the patient has prematurely aging appearance with short stature and osteopenia. So the differential diagnosis of Ehlers Danlos syndrome include Cutis Laxa. It is different from Cutis Laxa that the skin is hyperextensible and retains its recoil in Ehlers Danlos, while since Cutis Laxa is a defect of elastic tissue, so the skin lacks the recoil and elasticity, and it is redundant and hangs in folds. Then hyperextensible skin is also seen in Turner syndrome, but Turner syndrome is characterized by dwarfism, cubitus valgus, and webbed neck. Hyperextensible skin with abnormal elastic fibers in papillodermis is reported in the rare cartilage hair hypoplasia syndrome. Vascular Ehlers Danlos comes in the differential diagnosis of autosomal dominant aneurysmal disorders, Loeys-Dietz syndrome. Marfan syndrome is considered if the presenting vascular complication is aortic aneurysm or dissection. Then brittle cornea syndrome is a rare autosomal condition that shows significant phenotypic overlap with Ehlers Danlos type 6A. The disease course and prognosis. The prognosis of Ehlers Danlos depends on the subtype. A physical mental development are normal in hypermobile and classical type. Life expectancy is not reduced, hence large family pedigree are not unusual. An investigation molecular characterization should be sought whenever possible. Baseline echo for assessment of valvular prolapse and aortic dilatation. Adults with vascular Ehlers Danlos syndrome are risk of arterial aneurysm and rupture. Hence, non-invasive vascularization of arterial tree from head to iliac artery is indicated. Patient with significant reduced physical activity, the DEXA scan is recommended to assess for the low bone density. So the management is a multidisciplinary approach involving appropriate specialists, and patients should receive the genetic counseling as it is an autosomal dominant disorder, and the children affected or non-affected should not marry among the family. Then for joints, patients should avoid excessive activities that produce additional stress on their hypermobile joints. Physiotherapy is aimed at increasing the muscle tone and strength around the joints. Then skin precautionary measures to lessen the chances of trauma, scarring, and bruising. Children are advised to stop the contact sports like rugby, football, and excessive sun exposure to minimize the sun damage should be started earlier. High-dose vitamin C, 1 to 4 grams per day, reduce bruising and can also improve wound healing. Especially in patients with Kyphos Scoliosis type, wound should be closed without tension, preferably in 2 layers, and deep stitches should be applied generously. The cutaneous stitches should be left in place for twice as long as in a normal skin. Pregnancy is important because pregnancy represents a special issue. Maternal risks include cervical insufficiency, uterine prolapse, uterine tear, poor wound healing during the postpartum period, and excessive bleeding both during and post-delivery. It is unclear whether elective cesarean section reduces these risks, and patients should be managed in specialized obstetric units with multidisciplinary input. Infantile risks include premature rupture of membranes with secondary premature delivery. So vascular Ehlers Danlos syndrome needs avoiding trauma, including physical contact sports, and avoid activities that raise the intracranial pressure by Valsalva effect. Bleeding should be managed conservatively if possible. Ciliprolol is a long-acting beta-1 antagonist with partial beta-2 agonistic properties and is shown in randomized trial to reduce the incidence of arterial dissection of rupture by 3 times. So the next disorder I'm going to discuss among the inherited or genetic defects in collagen is the Prolidase deficiency. It's a rare inborn error of collagen metabolism associated with chronic skin ulcerations, mental retardation, and recurrent respiratory infections. The prolidase or peptidase D is involved in the later stages of degradation of endogenous and dietary proteins and is particularly important in collagen catabolism. This is a rare disorder occurring in 1 to 2 million births, and less than 100 cases are reported. Feature typically first appear in infancy to young adult life. There is an equal sex incidence, while slightly more common in Israel. The associated disease. Approximately 10% of cases are reported in association with SLE. Therefore, prolidase deficiency is a risk factor for development of SLE due to loss of immune tolerance to lupus-associated autoantigens. Pathophysiology. There is a decreased prolidase activity, therefore leads to impaired collagen synthesis and wound healing. It is not well understood how the prolidase deficiency causes other different clinical features. The light and electron microscopy of cultured fibroblasts from the affected patient suggests necrosis-like cell death with abnormal plasma membranes and mitochondria and increased cytosolic vacuolation. The genetics is an autosomal recessive trait, and mutations in prolidase gene result in loss of prolidase activity. Heterozygous have no clinical features. Clinical features. The most characteristic feature is a recalcitrant skin ulcer and fragile skin. The ulcers are difficult to heal. Most patients have intellectual and developmental impairment and abnormal faces, including prominent eyes with hypertelorism. Hypertelorism is increased distance between the medial canthi. A high forehead, saddle nose, and microgenthia. Microgenthia is small mouth. The skin changes occur in 85% of the cases. The skin feels spongy with pitting and scarring, especially on legs. Occasionally, there may be photosensitivity, telangiectasias, purpura, premature graying, and lymphedema. Splenomegaly, recurrent skin, ear, and chest infection, and obesity and protuberant abdomen occur in 30% of the cases. So among the systemic signs, splenomegaly is the most important. Prolidase deficiency is a chronic condition. So you can see the faces, the saddle nose deformity, and multiple scars on non-healing scars on the hand. Again, a very bad non-healing scar. Investigations. Large amounts of aminopeptides are excreted in the urine, and proline hydroxyproline ratio in collagen is increased. There is reduced or absent prolidase activity can be detected in red and white blood cells or cultured fibroblasts. Treatment is limited to improving the skin ulcers. First line is topical 5% proline and 5% glycine combination in ointment base, which is shown to be more effective as compared to topical 5% proline alone in healing the leg ulcers. Oral proline administration produced no clinical improvement. Now, in second line, a combination of topical and systemic growth hormone healed the recalcitrant leg ulcer in one patient and dapsone in another. Enzyme replacement by transfusion of Prolidase containing red cells or pulse corticosteroids and apheresis exchange have improved in skin ulcerations. Then comes the third condition associated with collagen defects, genetic collagen defects, is osteogenesis imperfecta. It is a heterogeneous group of heritable disorder that is characterized by osteoporosis with fracture due to predominantly type 1 collagen abnormality. In 2009, Sillens classified osteogenesis imperfecta into type 1 and 4, 1 to 4. Since then, further subtypes are identified and classified, expanded due to new molecular findings. The condition affects 1 in 15,000 individuals. Age of onset depends upon the severity of the disease. The severest form are lethal perinatally, while the mildest form not being diagnosed until adult life. There is no sex bias, no racial bias. Associated disease, it is associated with Ehlers Danlos syndrome because both are collagen defects. Pathology, bones are markedly collagen deficient and have distorted architecture. Genetics, it's an autosomal dominant trait with high frequency, 25 to 30% of de novo mutations. The mutations are seen in mainly collagen 1A1 or collagen 1A2 genes in 95% of the cases. Clinical features, in addition to thin fragile skin, there is recurrent fractures, skeletal deformities, and mild joint hypermobility. There is abnormal dentine formation, which is called as the dentogenous imperfecta, blue sclera, defective deafness, hernias, mitral valve prolapse, microvascular fragility leading to bruising. So the clinical variants, type 1A or the classical type. Commonest form, inherited as autosomal dominant. Fractures are common in childhood. Sclera are blue or gray, easy bruising. Early onset deafness. Joint laxity is common, and the incidence of mitral valve prolapse is increased. And aortic valves are thin and occasionally incompetent as well. Type 1B have dentogenous imperfecta, but dentogenous imperfecta is more seen in type 4. Then type 2 is lethal perinatal form of osteogenesis imperfecta. There are multiple fractures in utero. Infants rarely survive for more than a few days after birth. Radiographs show beaded ribs, crumpled femora, and little skull calcification inherited as autosomal dominant. You can see the distorted forearm bones, then scoliotic curves, blue sclera. Type 3 is progressively deforming type. In this condition, there are fractures in utero or at birth, and long bones are thin and occasionally cystic. As the child grows old, progressive scoliosis and bowing of long bones occur, leading to crimpling deformities as you see in the other picture. Sclera are blue in childhood, and type 4 is the mildest form with blue sclera. So the condition is similar to type 1, but sclera are not blue, normal sclera, not blue, and dentogenesis imperfecta is frequent and deafness is rare. So the type 4 is characterized by milder features, but sclera are not blue, and dentogenous imperfecta is seen. The disease course and prognosis, despite complication of osteogenesis imperfecta, the children and adults lead a productive and successful life. Differential diagnosis, patient with short extremities and large skull is confused with achondroplasia, but bone fragility and thin skin do not occur in achondroplasia. There is multiplicity of fractures seen in osteogenesis imperfecta, and investigations include the prenatal diagnosis of more severe form is possible using ultrasonography at week 16. The preferred examination for initial investigation of osteogenesis imperfecta is a plain radiograph. Management, a multidisciplinary approach, including the medical, orthopedic, physiotherapy, and rehabilitation, is required with the aim to preventing fractures and disability and improving function and quality of life. First-line treatment is bisphosphonates and becomes a standard care for patients with the condition, although it's unclear how long therapy should be maintained. The ongoing prevention of vitamin D and deficiency is important. Then second-line treatment is somatic cell therapy using allogenic bone marrow and mesenchymal stromal cell transplant. Then we have come to the inherited disorders of the elastic fibers. So these disorders we are going to discuss in two subheadings, that is the elastinopathies. The first condition we are going to discuss among the elastinopathies is the inherited generalized cutis laxa. So the cutis laxa is characterized clinically by lax pendulous skin that only slowly recoils when pulled. Histologically, there is loss and fragmentation of elastic tissue in the dermis. In the heterogeneous condition that is inherited or acquired, the inherited forms include autosomal dominant type, severe autosomal recessive type, and X-linked type. The clinical presentation and mode of inheritance show considerable heterogeneity. Cutis laxa variably affect other parts of the body, including head, blood vessels, joints, intestine, and lungs. The prevalence at birth is 1 in 1 million. Autosomal recessive type are more common. Presentation is at birth or early infancy, although autosomal dominant type has later and milder onset. Both sexes are affected equally in autosomal dominant and recessive form. In X-linked cutis laxa, only males are affected. There is no racial variation. Associated diseases. It's important to differentiate cutis laxa from other inherited disorder of connective tissue, although it may also accompany disorders such as pseudoxanthoma elasticum and Ehlers Danlos syndrome. Pathophysiology. Cutis laxa is caused by disruption of normal elastic tissue function. The defect is in fibrillin 4, fibrillin 5, and latent transforming growth factor beta binding protein and modifications and secretions of elastic fibers. Pathology. The skin is of normal thickness, but elastic fibers are sparse, short, fragmented, clumped, and particularly in upper dermis, they show granular degeneration. Similar changes in elastic fiber may occur in lungs and in aorta. The clinical variants. The autosomal dominant type of cutis laxa, the skin changes may develop at any age, but tend to be persistent later than in recessive form. Skin is soft and variably hyperextensible. Facial dysmorphism is mild, but beak nose is common. The autosomal dominant cutis laxa is considered to be milder form of the disease. Systemic involvement can range from mild to severe, that include bronchiectasis and emphysema, hernia, mitral and tricuspid valve prolapse, pulmonary stenosis, aortic and arterial dilatation and tortuosity, gastrointestinal and urogenital diverticula. You can see the widely stretched stria and loosely fold skin in the lower abdomen. Then comes the autosomal recessive type of cutis laxa, which is categorized into type 1, 2, and 3. 3 is the de-Barse syndrome. This is a severe form, and infant and childhood mortality is high. Typical facies is downward slanting palpebral fissure, a broad flat nose, sagging cheek, and large ears. prominent skin folds around the knee, abdomen, and thighs. Hernia diverticulum, arterial tortuosity and aneurysm, severe pulmonary emphysema, and core pulmonary and development delay are variable but important complications. Death due to respiratory complication is common in first few years of life. The deep Marfan syndrome, which is distinguished by the developmental delay and corneal clouding, is due to degeneration of tunica elastica of the cornea. Then autosomal recessive of the cornea. Then the X-linked recessive form or occipital horn syndrome, affected male in occipital horn syndrome, previously known as Ehlers Danlos syndrome type 9, have defect in distribution of intracellular copper or copper-dependent enzymes. The lysyl oxidase is the major copper-dependent enzyme, and its activity is markedly decreased, resulting in defective collagen and elastic crosslinks. The occipital horn syndrome is considered to be less severe form of the Menkes syndrome, but both conditions are caused by mutation in ATP7A genes. The clinical manifestations include the development of bladder diverticuli during childhood, inguinal hernia, mild laxity of skin, and skeletal defects such as short humeri and clavicle. Bony occipital horn appears during adolescence. The differential diagnoses of Cutis Laxa include the Wrinkly skin syndrome. Skin changes are limited to abdomen, hands, and feet, and facial dysmorphism is less pronounced. Then acquired Cutis Laxa may rarely develop at any age, but often follows an inflammatory process or an associated disorder. In Ehlers Danlos syndrome, skin is hyperextensible but not lax, and it recoils quickly, but this does not happen in Cutis Laxa. There may be circumscribed fold of lax skin in neurofibromatosis, and loose folded skin may also occur in leprechaunism, Patterson syndrome, and trisomy 18, but these conditions are distinguished by their associated features. Investigation. A skin biopsy is helpful. Echo and chest X-ray, lung function test should be performed. Neurological examination imaging is mandatory as in autosomal recessive type of Cutis Laxa. Acquired Cutis Laxa is suspected when then a primary cause should be sought. Molecular testing is possible for congenital and inherited Cutis Laxa. Management is limited and directed towards alleviating the complications. Surgical removal of lax skin can be undertaken as patients generally heal well, although the benefits are not long-term. Botulinum toxin is successfully used in less invasive modality to improve the facial defects, and the parenteral copper histidine treatment has been of benefit to patients with Menkes disease. It appears to have less effect on connective tissue abnormalities. Then is the Buren syndrome. Again, a multi-system disorder characterized by premature laxity of the skin, congenital heart disease, supravalvular, metabolic abnormalities, and dysmorphic facial features and developmental problems. It is caused by detection of William and Buren of chromosome region 7 containing multiple genes. It can start in early childhood and equal sex incidence. No racial bias is reported. Although Buren syndrome is not strictly an elastinopathy, it shares many clinical features associated with elastin deficiency. The epidemic of Williams syndrome was reported in UK following administration of excessive doses of vitamin D to prevent the rickets in pregnant women, and vitamin D is known to downregulate the elastin gene expression. As patient gets older, the features become noticeable and more coarse and full cheeks, prominent lips and dental. Premature graying of hairs can occur in young adulthood. Inguinal and other hernias develop. Endocrine abnormalities occur and include variable degree of hypercalcemia, glucose tolerance, and subclinical thyroid disease. Hypertension occur in approximately 50%, and cardiovascular complications are the major cause of death. Then, regular monitoring of calcium level and investigation of other endocrine associations must be performed. Management therapy. It is directed to specific complications, and surgery is preferred choice for arterial stenosis. Macklin type tire baby. The term refers to a very heterogeneous group of disorder manifesting as circumferential skin folds. The condition, it is not the lax skin fold as we see in Cutis Laxa. The condition is shown in some cases to result from underlying smooth muscle hematoma or adipose hyperplasia. Abnormal elastic fibers are reported. The disorders can be sporadic or inherited as autosomal dominant or recessive pattern. Diagnostic criteria to help better delineate the syndrome have recently been proposed with suggestion to rename the condition as circumferential skin fold syndrome. So this is a Macklin type tire baby with circumferential increase in skin tone. Then the inherited disorder of elastic fibers, which comes in the heading of fibrillinopathy. Marfan syndrome is one of the fibrillinopathy. It's an autosomal dominant disorder of connective tissue, mainly affecting CVS, skeleton, and ocular system. Full syndrome is characterized by aortic dilatation, ectopia lentis, and skeletal abnormalities. Individuals are disproportionately tall with thin with abnormally long extremities. Affect 1 into 5,000 to 10,000 individuals with no sex bias and no racial variation. The disorders which are associated with Marfan syndrome include Ehlers Danlos syndrome. Then Marfanoid phenotype is identified in congenital lipodystrophy and neuroma of eyelids and tongue with medullary carcinoma of thyroid and pheochromocytoma as a part of multiple endocrine neoplasms type 2B. Pathophysiology. True cases of Marfan syndrome are due to abnormalities in fibrillin 1, which is a component of elastin-associated microfibrils. Mutation in fibrillin 1 gene is located in chromosome 15q21.1 and encodes the fibrillin 1, causing majority and if not all cases of Marfan syndrome. Mutation in gene of transforming growth factor beta receptors is also identified in number of disorders with phenotypic overlap with classical Marfan syndrome. The clinical features. The full syndrome comprises of skeletal, ocular, and cardiovascular defects. The patients are exceptionally tall with skeletal proportions are abnormal. The limbs are long, excess being greatly distal, giving an ericnodactyly. The simple screening tests include thumb sign, positive if thumb, when completely opposed in the clenched hand, projects beyond the ulnar border, and the wrist sign that is positive if thumb and little finger overlaps when wrapped around the opposite wrist. So you can see the tall individuals, and the main height is distally, that is from the knee to the toe and from the elbow till the end of the fingers. So these are abnormally long So there are eye problem, abnormal chest and heart problems. Then this is the thumb sign. If you make a fist, then thumb projects beyond the ulnar border. And this is the wrist sign in which the thumb and the little finger overlaps the wrist. Skull is dolichocephalic, that is long and high. Paranasal sinuses are large, and the palate is high and arched. Skeletal changes include hyperextensible joint, Kyphos Scoliosis, pectus excavatum, and flat foot. Muscles are underdeveloped and hypotonic, and subcutaneous fat is sparse. Common ocular problems are ectopia lentis, trembling iris, also known as iridodonesis, myopia, retinal detachment, blue sclera, and heterochromia of the iris. There is aneurysmal dilatation of ascending aorta, which is the most important abnormality of CVS, resulting in fatal complications. Then aortic and mitral incompetence and mitral valve prolapse are both common. Cutaneous abnormalities include elastosis, serpaginosa perforans, stria atropicans, peperaceous scars, and skin hyperextensibility. Other abnormalities include the nerve deafness, pulmonary malformations, renal abnormalities manifest as proteinuria and microhematuria. Neonatal Marfan Syndrome is the most severe end of the spectrum, with death in first year of life due to congestive heart failure as a consequence of significant atrioventricular valve dysfunctions. The differential diagnosis of Marfan syndrome is homocystinuria due to cytathione beta synthetase with myopia and downward ectopia lentis, then Shepard-Goldberg syndrome, Weil-Marchesni syndrome, and Beal syndrome. The disease course and prognosis. Aortic dissection is the most common cause of mortality. The introduction of beta-blocking agents, angiotensin II receptor 1 blockers, has improved the patient greatly, and treated patient can have a normal life expectancy. So the management include beta blocker therapy. We use since many years. Most recently, angiotensin converting enzyme inhibitors are advocated due to their inhibitory effects on circulating, transforming growth factor beta. Addition of losartan reduces the aortic root dilatation. A number of criteria exist to determine the need of aortic root surgical intervention in adults that include the aortic root diameter of greater than 50 mm. This is an index for body surface area. The last part of today's lecture is the infantile stiff skin syndromes. Hyalinosis fibromatosis syndrome. The hyalinosis fibromatosis is one of the several rare syndromes caused by hard, stiff skin and joint contracture in early life. Rare allelic autosomal recessive disorder of connective tissue with overlapping clinical features comprising of progressive joint contractures, skin papules and nodules, and chronic pain. Presentation is in infancy and in childhood. No sex predilection and no racial predilection. Pathology. The dermis is thick with deposition of hyaline eosinophilic material. The hyaline material may be present in other tissues, including bowel, muscle, and bone. The dermal collagen is decreased, and collagen fibrils are fewer and thinner than in the normal skin. The infantile systemic hyalinosis is most extreme variant, characterized by skin becoming diffusely thickened and hard in first few weeks of life with limited joint mobility. Then papules and nodules may be present at birth or developed during early childhood, particularly on the face, neck, and perianal region. In milder phenotypic spectrum, juvenile Hyalinosis fibromatosis, onset is delayed until 3 months to 4 years. The other variable features include the gingival hypertrophy, painful swollen joints with contractures, hypotonia, osteopenia, diarrhea, hypoproteinemia, and severe infection and growth failures. But the main feature is the skin becoming diffusely thickened with papule and nodules and limiting the joint mobility and pain. So these are the patients with multiple papule and nodules and limited movement. The differential diagnoses include Winchester syndrome, stiff skin syndrome, lipoid proteinosis, congenital generalized multiple fibromatosis, and mucopolysaccharidosis, or the Hunter syndrome. The prognosis is poorer with severe form of hyaline fibromatosis, and survival beyond 2 years is unlikely. It is mostly due to recurrent respiratory infection and diarrhea. Most patients of juvenile type survive until 4th decades. Management. Treatment of the disease is limited to symptomatic relief. Joint contracture respond to intralesional steroid injection in early stage and also respond to systemic steroids and physiotherapy. Tumor nodules do not respond to radiotherapy and they may recur after excision. Then the stiff skin syndrome. Stiff skin syndrome is one of the several rare syndromes caused by causing hard, stiff skin and joint contractures in early life. Features present in infancy or early childhood, no sex bias. Mutation is seen in integrin binding domain of fibrillin 1 leading to altered cell matrix interactions. And similar observations are seen in scleroderma. Pathology, deep sclerosis is found with lattice-like array of thickened, horizontally oriented collagen bundles in absence of the inflammation. So in this case, there is true collagen bundle proliferation resulting in thick and horizontally oriented collagen bundles. Genetics: in autosomal dominant disorder due to mutation in fibrillin 1 gene encoding for integrin binding domain of fibrillin 1. Patient present with diffuse firm thickness of the skin, leading to reduced joint mobility and causing flexion contractures. The variable features including hypertrichosis, short stature, lipodystrophy, muscle weakness, cutaneous nodules over distant interphalangeal joint, and diffuse entrapment neuropathy. Internal organs are not involved. The disease is slowly progressive, and so progression of skin involvement. There is no specific treatment, but physiotherapy is important to help reduce the mobility, to help with reduced mobility. You can see this stiff skin syndrome, where the skin is overall stiff and joints are immobile because of the stiff skin. Winchester syndrome is again a stiff skin syndrome. The Winchester syndrome includes a heterogeneous group of inherited osteolysis or vanishing bone syndrome. Bone and joint abnormalities are the main features. Inheritance is autosomal recessive, and mutation is MMP14, encoding for matrix metalloproteinase. A disease of infancy characterized by joint contracture, osteolysis, particularly of hand and feet, osteoporosis, arthralgia, dwarfism, gingival hypertrophy, corneal opacity, and hypertrichosis. The skin is diffusely thickened, leathery, with areas of hyperpigmentation and symmetrical restrictive banding of skin. Abnormal ECG changes suggest myocardial damage. Complication: there is progressive osteolysis that lead to loss of functions of large or small joints. Prognosis is relatively good and many patients survive into adult life. The osteolytic changes are detectable by plain radiographs, and there is no specific therapy, and treatment is aimed at symptomatic relief of the patient. So this brings end to this talk. Although it was a difficult talk with many features, but I advise you to just concentrate on the major features of every syndrome because it is impossible to remember the minor features. So the major features should be remembered. An important thing to remember is the classification, that which of the syndromes are due to defect of collagen and which of the syndromes are due to defect of elastin. So in all the conditions which are due to defect in collagen, the skin and joint retain their elasticity. While in all the conditions that are related to defect in elastin, the skin is lax and hangs and folds. So just remember this difference. Thank you and have a very good day.